Welcome to today's session on bacterial infections of the central nervous system. Before we dive into the mechanisms of infection, let's understand why certain bacteria successfully invade the CNS while others cannot. The key lies in two critical factors. First, the bacterial virulence factors that allow pathogens to evade our immune defenses and cross protective barriers. And second, the specific routes these organisms use to reach the brain and spinal cord. Understanding these concepts is fundamental because it explains not only why certain bacteria cause CNS infections, but also helps us predict which patients are at highest risk and guides our approach to prevention and treatment. The most important virulence factor is the polysaccharide capsule. This outer coating acts like an invisibility cloak, helping bacteria resist phagocytosis. The three most common causes of bacterial meningitis, Neisseria meningitidis, Haemophilus influenzae, and Streptococcus pneumoniae, all possess thick polysaccharide capsules. This is not a coincidence. The capsule is essential for their ability to survive in the bloodstream long enough to reach the CNS. Some bacteria go even further. Neisseria meningitidis and Haemophilus influenzae produce an enzyme called IgA protease. Remember that IgA antibodies are our first line of defense on mucosal surfaces like the nasopharynx. Bi produces IgA protease, neutralizing this protective barrier. Next, let's talk about pili. It allows bacteria to attach firmly to the nasopharyngeal mucosa, establishing colonization. Another weapon is endotoxin, which triggers massive inflammatory responses, causing fever, shock, and the characteristic symptoms of meningococcal sepsis. Speaking of E. coli K1, the K1 refers to a specific capsular type that is particularly associated with neonatal meningitis. Finally, Streptococcus agalactiae, also known as Group B Streptococcus or GBS, possesses a capsule that helps it cause meningitis in newborns, particularly in the first week of life. There are three major routes of infection, and understanding these routes is clinically crucial because they determine both the organisms involved and the clinical presentation. The first and most common route is blood-borne spread, also called hematogenous spread. This accounts for the majority of CNS infections. Bacteria enter the bloodstream from a distant infection site and then travel through the circulation to reach the brain and meninges. The second route is direct spread from adjacent infected sites. Think of this as bacteria breaking through from neighboring structures, like infection spreading from the middle ear, mastoid, or sinuses directly into the CNS. This typically occurs when there's severe, untreated infection in these adjacent structures. The third route involves traumatic or surgical breaches of the protective barriers. This includes skull fractures, neurosurgical procedures, or the presence of foreign devices like shunts. Essentially, these create artificial pathways that bypass the normal protective barriers. There's also a less common fourth route involving intraneural pathways, where certain viruses travel along nerve fibers themselves to reach the CNS. While less common, this mechanism is important for specific pathogens. Blood-borne spread begins with bacteremia or viremia, the presence of bacteria or viruses in the bloodstream. This bloodstream invasion usually results from infection at a site remote from the CNS. Here's the critical point. For CNS infection to occur, the pathogen must not only survive in the blood, but must also successfully penetrate the blood-brain barrier. So how do bacteria breach this barrier? They use the virulence factors we discussed earlier. The classic organisms that cause CNS infection via bloodborne spread include Haemophilus influenzae, Neisseria meningitidis, and Streptococcus pneumonia. Notice these are the same encapsulated ones. An important clinical concept here is that the initial source of infection may be occult or overt. Occult means hidden. For example, bacteria may be multiplying in reticuloendothelial tissues like the spleen without causing obvious symptoms before spreading to the CNS. Overt sources are clinically apparent. A patient with pneumococcal pneumonia who develops meningitis, or a child with pharyngitis who develops meningococcal disease. The second major route involves direct spread from infected structures that are anatomically close to or contiguous with the CNS. This is sometimes called contiguous spread. Think about the anatomy for a moment. The brain and spinal cord are surrounded by bone and membranes, but they're also neighbors to structures that can harbor infection. The most important adjacent sites include the middle ear, the mastoid air cells, the paranasal sinuses, and occasionally pyogenic infections of the skin or underlying bone of the skull or spine. Let's consider a clinical example. A child with acute otitis media, middle ear infection, that goes untreated or doesn't respond to antibiotics. The infection can erode through the thin bone separating the middle ear from the meninges, allowing bacteria to spread directly into the subarachnoid space, causing meningitis. Similarly, mastoiditis, infection of the mastoid air cells behind the ear, can extend into the posterior cranial fossa. The organisms involved in contiguous spread reflect the flora of the primary infection site. You'll see Haemophilus influenzae, Streptococcus pneumoniae, and Neisseria meningitidis spreading from respiratory sites. This route of infection is particularly important clinically because it explains why aggressive treatment of ear infections, sinusitis and mastoiditis, is crucial. It also explains why patients with chronic ear disease or recurrent sinusitis are at higher risk for CNS complications. The third route involves breaches of the normal protective barriers through trauma or medical procedures. Let's conclude with fractures of the skull but important routes of CNS infection because they can create congenital defects which represent a special category of direct communication. Specifically, basilar skull fractures may damage the cribriform plate, where the spinal cord creates a direct connection between the nasal passages and the subarachnoid space, in the lower back. Because all create an obvious communication between nasal passages and the mastoid and middle ear, putting children at high risk for respiratory tract, particularly the upper respiratory tract is colonized with potentially pathogenic bacteria as part of our normal flora. When there's a fracture creating a pathway, these normally harmless colonizers can become dangerous invaders. Neurosurgical procedures present similar risks. Any operation that opens the skull or spinal canal creates a temporary communication between the sterile CNS and the external environment. Shunts are particularly problematic. When bacteria adhere to the shunt material, they often form biofilms, protective communities of bacteria that are extremely difficult for antibiotics and immune cells to eradicate. Staphylococcus epidermidis, a normal skin organism, is the most common culprit in shunt infections, precisely because it's introduced at the time of shunt placement and has an affinity for foreign materials. Finally, let's discuss intraneural pathways, a completely different mechanism used primarily by viruses. The classic example is rabies virus. After inoculation through an animal bite, the virus enters peripheral sensory nerves at the wound site and travels retrograde, backward along the nerve, all the way to the brain. The virus is slowly traveling along nerves. Herpes simplex viruses, HSV1 and HSV2, also use intraneural spread. HSV1 typically establishes latent infection in the trigeminal nerve ganglion after primary oral infection and can reactivate to cause herpes encephalitis. Polioviruses also use neural pathways, though polio is now rare due to vaccination. The virus would travel from the gastrointestinal tract to motor neurons in the spinal cord. Understanding intraneural spread is important because it explains why certain viral CNS infections have characteristic presentations, like why HSV encephalitis affects the temporal lobes preferentially, and why antiviral therapy needs to be started promptly before extensive neural spread occurs.